Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, you ready to talk about some thyroid?
You bet your sweet pippy I am, Matt.
Paul, are thyroid nodules common? I heard they're not. Is that wrong?
We're starting strong. Yeah, they're very common, Matt, and they become more common as we age. And the reassuring thing is that most of them are benign, and most of them are actually found incidentally. And I think we talked about this on the episode. This is even more common now that we're doing all this low dose lung cancer screening, which is wonderful. But we're finding all these incidental things, including thyroid nodules, on these scans. And one nice thing to tell patients when we're starting the initial workup is that by and large, these are extraordinarily common and they are also usually benign, though not always. And we'll get into that a little bit. So, Matt, if someone were to have one, what kind of symptoms would you be asking the patient about?
So, I would not have thought of this, but apparently one of our guests, Dr. Chidris, said that she actually asked people about neck tightness. That can be one of the symptoms that people will have. She asked about compressive symptoms, voice changes, things like that, but also just the classic hyperthyroid symptoms or hypothyroid symptoms. So, heat intolerance, palpitations. And she said that actually, and this might have been just anecdotal, but I thought it was a cool anecdote. One patient had like a personality change that the family thought might be related to the thyroid, and it did get better when the patient had their thyroid hyperthyroidism treated. So, take that for what you will, audience. But that, I guess, personality changes are on the list as well.
I mean, I guess it's one of the ththings that we always check when someone is just feeling kind of different or behaving sort of off. So maybe this validates that to some extent.
But Paul, I'm going to be real with America here, the people watching this. Paul, I don't know that I've ever been feeling someone's thyroid and been like, oh, you have a dominant nodule on the left side of this. I feel like I feel the thyroid. I'm good at noticing if someone's thyroid is so big that I can visibly notice it without even touching them.
Great.
But thyroid nodules are difficult to feel. Tell us a little bit about that, Paul. You're the physical exam guy.
Yeah, it turns out, I think even over a centimeter, if I remember the episode right, we miss about half of them with physical examination. They're just tough and they're really hard to feel you're not going to feel them if they're less than 1 centimeter, and especially if they are located posteriorly, your chances are really sort of slim and none. So these are not typically things that we find on examination, though. If they're large enough, I suppose that you could, but don't beat yourself up. We do talk about the various techniques, and I think, when we were in medical school was, stalk the patient from behind and wrap your hands gently around their neck, and then they're drinking out of a straw. It's a whole forehand production, but
I think on the episode you described, so how are we doing this? Are we still sneaking up behind them and choking them? Yeah. I like I think it was Dr. Susan Mandel. She said she examines from the front, one side at a time, using her thumb, and I think that's a good way to go.
Yeah, the one side at a time is clutch for sure.
Yeah. And I guess it's okay, again, to give a patient a cup of water, have them swallow so you can feel the thyroid go up and down. I had stopped doing that for a little while too, probably because of laziness. There's not cups in my office, but I think it's a good practice if you have that around.
Sure, and if you're feeling thyroids all day, it's probably
yeah. Paul, the testing for this is pretty simple. TSH is still going to be the workhorse here, and then you're basically looking to see if you're finding a nodule, you're looking to see, is this a hot nodule? Could this person have Graves? Depending on what you're seeing or feeling on exam. So TSH, and you don't necessarily have to get free T4 or T3 for every single person, but sometimes you can. And we asked about calcitonin because that had come up. And calcitonin, really, there's not really a role for it anymore now that we have, if you are proceeding with an FNA, they have these molecular tests to try to figure out which type of thyroid cancer it might be. So there's not a huge role for calcitonin. So it's just a pretty basic workup, the TSH. And then ultrasound can really shine here, Paul, still. So, Paul, have you ever ordered a radionuclide thyroid scan?
No, I have not. I think I've seen it on certain algorithms and thought, boy, if I'm thinking about that, I should probably have them see endocrinology anyway, as is my way. But I've never pulled the trigger on one myself, and I'm not even sure I've seen one ordered by Endocrine, at least not in the past 5 years, I don't think.
Yeah, our guest, Dr. Chindris, she basically said she might order them sometimes, if you're pre-opping somebody, but a lot of the times nowadays, even if someone has Yeah, like even if someone is seeing an endocrinologist, they're not necessarily getting them. So I would say in primary care, if you're practicing on your own, you're probably not going to be ordering these too often. But I guess it depends on your, I don't think it's necessarily the wrong thing to do. It's just you don't have to do it. Uh,
There are often easier ways to go about it, I think. Yeah.
yeah, yeah. And when you get the ultrasound report, you're going to get your they have a TIRADS, much as like they have a BIRADS for mammograms, and the higher the number, the worse. It goes from 1 to 5. 5 is highly suspicious, and when you get cytology, if they do a fine needle aspiration, you're going to get this Bethesda categories, which go from 1 through 6, 6 being malignant, 1 being non-diagnostic. Too much to get into on this video, but definitely if you want to hear the full episode, we talk through those. And then, Paul, let's talk about GLP-1 agonists, because I believe, Paul, tell me if this is wrong, that everyone who's on a GLP-1 agonist should probably have yearly, maybe twice yearly, thyroid ultrasounds just as standard.
That might be a bit over aggressive. So I probably most of the people watching this know that if someone has either a personal or family history of multiple endocrine neoplasia, that would be a reason to not pull the
Mhm.
trigger on the GLP-1 agonists. I think probably many of us have gotten a little bit squirrely just in terms of thyroid cancer in general. You know, if there's a history of papillary thyroid cancer, like, ooh, is this still okay? And it's one of those things I think early on, at least when these agents were starting to be used, we would at least have to look up every time and still had a
Right.
little bit of trepidation about. But now, um, or I guess say they have plenty of patients with a history of thyroid cancer, not medullary, but other types, the differentiated types that they treat with GLP-1 agonists and don't have any underlying concerns about. So I don't know that we need to be doing serial ultrasounds, but Matt, oftentimes I feel like the patients come to us and they may not know specifically what type of thyroid cancer they have. So do you remember
Right.
the party trick in terms of how to differentiate that?
Yeah. I thought this was good. Okay, so what you're saying, Paul, is that if I was wrong, so if someone's on a GLP-1 agonist, I don't have to routinely check a thyroid ultrasound,
Yes, correct.
but I should ask them if they've ever had if they have medullary thyroid cancer in their family, or if they've had MEN2A, and then if they're not sure what they've had, then you can ask them, have you been treated with radiation or thyroid suppression, like suppressive doses of thyroid hormone? Because if they have, then that's probably they were probably treated for a well differentiated thyroid cancer. You would not treat medullary thyroid cancer with radiation or suppressive doses of levothyroxine. So that's a good way to kind of figure out what type they have. And I mean, anaplastic, unfortunately, it's just such a wild thing, and it's such a poor prognosis. You're probably not going to be meeting someone 10 years down the line that doesn't remember.
Right.
Like she said, those patients know if they had that type.
Yeah.
Yeah. So the party line right now, and the research would suggest it is safe to give GLP-1 agonists to patients who have had thyroid cancer or who have thyroid nodules. It's just if they have medullary thyroid cancer or MEN2, then multiple endocrine neoplasia, the two, then you would not do it. So that's good news, Paul, because that's a lot of people out there taking
That's a good
these,
chunk of
and
patients.
thyroid cancer is relatively common. So. All right, everybody. Well, if you want to hear the full episode with our two excellent guests, then click on the link in the transcript below. And with all that, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Sure enough, Matt, and I remain Dr. Paul Nelson Williams. Thank you and goodbye.